Hi, this is Dr. Mohammad Faizan Pazad, and this is first lecture on basics of interpreting HRCT. This is just the basics, and I suggest that once you complete this course, come back to this lecture again and start over. With 2 or 3 revisions, you will be good to go. When interpreting chest CT in this video, we will focus on the anatomy of the secondary pulmonary lobule. You will also have the opportunity to pause and answer some questions to test your knowledge. Knowing the anatomy of the secondary lobule will help you better recognize key patterns of disease. When interpreting chest CT, pause the video here and see if you can assign a label to each of the structures represented by the different colors in this image. If you can't, don't worry. After completing this video, you will be able to name all 6 structures. Welcome back. Let's go through the answer to our question. Interlobular septa are represented in yellow. The central-lobular bronchiole is represented in pink. This is also called the interlobular bronchiole. The central-lobular arteriole is represented in blue. This is also called the interlobular arteriole. Intralobular septa are represented in purple. Interlobular venules are represented in red, and lymphatics are represented in green. Next, we will review each of these structures in more detail to help us understand the secondary lobule itself. Let's look at a chest CT from a patient with pulmonary edema. The interlobular septa are not visible in normal lungs. However, in this example, edema of the interlobular interstitium and/or congestion of the interlobular venules has thickened the interlobular septa and made some secondary lobules visible. The diagram of the secondary lobule has been rotated here to match the alignment of the chest CT. The secondary lobule is the smallest functional unit of lung that is demarcated by connective tissue septa, called the interlobular septa, seen here in yellow. Secondary lobules are supplied by a centrally positioned bronchiole called centralobular or interlobular bronchiole, shown here in pink. It branches within the secondary lobule into interlobular bronchioles, then respiratory bronchioles, eventually ending in gas exchange units. Centralobular bronchioles are usually not visible in high-resolution CT scans. If centralobular bronchioles are visible, this signals disease and typically creates a pattern described as centralobular nodules. Here we see centralobular nodules in a patient with endobronchial tuberculous mycobacterial infection. The centralobular bronchioles are visible here because of mucus in the airways. The particular pattern shown here is also called tree and bud. The centralobular area tends to be the site of diseases that enter the lung through the airways, such as in respiratory bronchiolitis, central lobular emphysema, and hypersensitivity pneumonitis. You will learn more about central lobular patterns of disease in later videos. Secondary lobules are supplied by a centrally positioned arteriole called the centralobular or interlobular arteriole, seen here in blue, because, as you may recall, it carries deoxygenated blood from the right side of the heart into the lung for gas exchange. The arteriole branches within the secondary lobule into intralobular arterioles, then acinar arterioles, eventually ending in gas exchange units. In contrast with the centralobular bronchioles, centralobular arterioles are usually visible in high-resolution CT scans in healthy individuals. In addition to the arterioles and bronchioles, within the secondary lobule are a series of mesh-like connective tissue fibers called the intralobular septa or interstitium, seen here in purple. The intralobular interstitium supports the various structures by attaching them to the interlobular septa surrounding the lobule. This is a CT from a patient with carcinomatosis from gastric cancer. Here we see both interlobular septal thickening and ground glass inside the secondary lobule due to intralobular interstitial thickening. Here we see the interlobular septa in yellow. Again, the interlobular septa contain interlobular venules and lymphatics. The pulmonary venules are seen here in red because they carry oxygenated blood from the alveoli to the pulmonary veins and into the left atrium. We have represented them in red. As we saw earlier, pulmonary edema can present with interlobular septal thickening due to congestion of these venules, congestion of the lymphatics, or due to edema of the interlobular interstitium. The lymphatics are seen here in green. They run through the interlobular septa and along the central lobular bronchiovascular bundles. Thus, diseases associated with lymphatics, such as sarcoid and lymphangitic carcinomatosis, can cause abnormalities in both the interlobular septa and the central bronchiovascular bundles. Here we have an example of a patient with lymphangitic carcinomatosis, resulting in septal thickening and thickening of the bronchial walls. The vessels also look larger than usual and probably have wall thickening as well. However, a CT with contrast would be required to better evaluate the blood vessels. In the next lecture, we will discuss the general approach to reading chest CTs and spatial distribution of disease.